2005 and 2008. And as we had a successful pilot that really showed that EMS could read and interpret a MOLS form, not just a non-hospital DNR form, we made this a statewide training. And Mike Daly was very instrumental in helping us as part of a work group, as part of the MOLS statewide implementation team to put this together. So Katie will scroll down. We have online training. There's continuing education training for EMS providers, key points that were put together, as well as all of the policy statements that the department has had. And as you scroll down, your policy statements, memos, and other resources, including some QA/QI that was used as the pilot and is now available statewide. So I wanted to show you that first to make sure everyone was aware of that and that it's there available for use. I would also say we're very open to any suggestions, and that's where Mike and the team that really bubbles up to the MOLS statewide implementation team provides feedback from the organizations through Remac, Remco, and now I know there's a Remo. But what we want to do is do a few slides and then show you a demonstration of eMOLS, and most importantly, get some feedback from you in terms of how EMS can access it. I want to first start with some slides that show you what's involved with eMOLS and what is it. eMOLS is basically an online completion for MOLS as a process. And it really is based on conversation, and there's discussion that comes in here, and it's only step 7 that you sign the eMOLS form. So those are the clinical steps that we teach the providers. In addition, what we have is, with Family Health Care Decisions Act, the legal requirements and how MOLS was completed has been dramatically changed. And so there are basically 7 different legal pathways, 5 for adults, and it's based on who makes the decision, where the decision is made. There's a level of complexity for folks that are really doing the discussions and doing it with all of the standards that are put into place with public health law. And it's really been a sea change as of June 1st, 2010. There's a checklist for minor patients for children, and prior to June 1st, 2010, parents really had no right to make these decisions under the law. They have rights now. And finally, there's a checklist for persons with developmental disabilities who lack decisional capacity. If they have capacity, they're treated as an adult. This is important because MOLS has been taken from withdrawal of care in an ICU out to the community. And this checklist needs to travel with the person and needs to be available for EMS in the community, and as people move across care transitions, so it must travel. The level of complexity here is all put into the eMOLS application. At the end of that process, a MOLS form is completed, or an eMOLS form, and it looks exactly like the DOH 5003 MOLS form. The MOLS became a Department of Health MOLS form when Family Health Care Decisions Act went into place. It also is able to populate a chart documentation form. That may not be important for EMS, but for the rest of the care transition team, it allows the documentation of the person's goals for care and how all of these legal requirements are made. And most importantly, this process is a smart form process. You won't get incomplete MOLS forms through eMOLS because it has to be done correctly. You won't have incompatible orders. Incompatible orders where some MOLS forms have been completed and an emergency occurs and they don't even call you, they're calling me as they're calling you. One case was with a form that said, do CPR. The backside said, do not intubate, do not hospitalize, do not do anything. And you're smiling because, of course, those are incompatible. It's not a promise that we can keep. And, you know, when the patient arrested in the nursing home who was frail and had low chance of survival, and if they did, they'd be transported to the hospital where they'd be in the ICU, and the literature would support that they would die there, inconsistent with any wishes because they weren't really done correctly, then this process doesn't allow for that to happen. So the only way that an eMOLS form can be done is a properly completed one, as well as one that doesn't have incompatible orders. In addition to this online completion, it's building a registry for the state. And so at some point in time, I will continue to talk about MOLS. I'm hopeful that when I need a MOLS, it will be an eMOLS, And as I continue to talk about MOLST, and I move from Rochester and I come back to Albany, if something were to happen to me here, that my MOLST form that was completed in Rochester would be accessible electronically in this registry to EMS here in the Albany area. A registry is basically a database that houses the eMOLST forms and is available 24/7. And that's where I've been talking to Mike, and I'd like to be able to get feedback from you in terms of how we would get access for EMS, and that's the important part when the rubber hits the road. The advantages are they're legible orders. They can only be completed correctly, no incompatible orders. It transfers to the RIOs. RIOs are Regional Health Information Organizations. There are about a dozen in the state, and they're all coming together at some point in time to create SHINY, the State Health Information Network of New York. That's not all ready yet. eMOLST is ready, so we're ready to work with systems to begin to get paper MOLST into eMOLST conversion. And when we get to a certain population of forms, we can then train eMOLST we can train EMS, on the eMOLST. We also have quality assurance and quality improvement built into this application. We have visions for it. We have a grant written so that we can actually build it, so we can get a sense of what's happening with MOLST across the state, which we don't have currently in the paper world. And our goals are to ensure accessibility of the forms, improve the quality assurance, and build those quality metrics that I just mentioned. And here's really a little schematic, and then we're going to do the demo. Anywhere that a provider who has a discussion can initiate an eMOLST, where there's a computer, there's access to this secure web-based application. Only physicians can sign it, as you know, and once that's completed, it can be saved as a PDF in the EMR. It can be printed for the patient, given to the patient, and we have said from a workflow perspective, it should be printed on pink because it's so important. EMS has been trained to look for that pink form. Automatically becomes part of the registry, and as the RIOs are built, we'll have accessibility. We have gone from just looking at a RIO-centric model in the Rochester area to seeing eMOLST as a RIO unto itself, and ultimately SHINY would be connecting throughout the state to this one registry. In terms of talking points, technology-wise, there's a application and there's a database, and there are two databases and two applications. One's in test, whereas we're working with systems, we begin to look at what works well, what do we have to fix, and then once we know it works in test, it goes into production. Production is the registry. There's a lot of HIPAA and data security that's built in, and you have to have both the application and the database. If there was any compromise, you would not be able to see any real data because it's all encrypted. We're also working on building mobile applications. We're moving down that pathway. Technology is moving so quickly. We're looking now as a mobile-friendly website, and this may be one of the solutions for EMS in terms of being able to get access. So with that, I think we're going to turn our attention to actually seeing the demo so that you can see how it's created. Katie's going to run it. It is a web-based solution. Everyone who has access to this eMOLST application gets a username from the system where they're doing it and a specific password. We have e-learnings that are built. They're loaded up on YouTube and our website. They're integrated into the application so that individual practitioners can learn eMOLST. Selection of the location of where it's completed is to build in analytics on the back end. May not be important to EMS, but from a system standpoint, if you're a hospital with multiple nursing homes and providers, you can see where MOLST is getting created. There's a list of patients that the provider can look at. We let them know the status and when there's a review and renewal date. We look at the eMOLST number, last name, first name, database, and their eMOLST status. We can search currently for a patient either by putting in first name, last name, gender, and date of birth, or if there is an eMOLST number, we can put the eMOLST number in. You'll see on the front of the MOLST form, it says this is not an eMOLST form if there is no eMOLST number. So either way, you can search for a patient to be able to get their eMOLST form. There are notifications that are built in so that the providers will understand what's been happening on that individual form. Currently, we have no way of knowing who's been touching that form, who's been part of the discussion, so it's all there. So we'll just look in and search for a patient, and if we don't find that patient, that is the first step. It'll say, please check and double check if it's not there, and we'll basically be able to see if there is an EMOS form, or if not, create one. And so at this point it says patient not found, so we can create a profile.
This is what providers would be doing.
And this is what providers would be doing, not from an EMS perspective, but giving you the background. It'll help you to understand what goes into it and what quality assurance is there. So this is the address, and a patient is created to ensure that the proper patient has been created and it's been done correctly, typed in correctly. It says, please double check your spelling, date of birth, because you can't change it. Now this patient has automatically been assigned an EMOS number. That's the number that you would look if you knew that number, or if it was accessible on a form that was available, or a system that allowed you to search for the patient by EMOS number. We can create the EMOS form, and this is what the providers who are creating it would do.
I'm sorry, custodianship.
And so one of the pieces that it's creating, but there are two little buttons there that I didn't mention in the interest of time. One is remove from custodianship or deceased. Multiple providers can have custodianship of the patient. If I have a patient in the EMOS system and they're transferred to the hospital, Mike, as the emergency room physician, can also be a custodian. If they're admitted to the hospitals can be. When they leave the hospital, it would be removed from custodianship. We also have the ability to track when people have died, and then to be able to access on a back end what their quality of care has been at the end of life. We go through the discussion. That's the 8-step protocol. It helps people to walk through the process correctly so that we're not just signing forms, and so that you can be assured as an EMS provider that when you see a MOLST and you've been trained, a MOLST means there's been a good discussion. And the result of the discussion are these medical orders signed by a physician. It helps providers to go through assessing health status, prognosis. Do they have directives? If they don't have advanced directives, if they don't have a healthcare proxy, do people still have the capacity to choose an agent? Then do they have medical decision-making capacity? Who is the decision maker? Where is it being done? And it automatically drives to those 7 legal requirements checklists, to not have to have the provider think, what do I need to do? It asks the patient what's important to them. This is information that doesn't normally get transferred across care transitions. What are their goals for care? A summary of the discussion is in the text box. All of this is really preferencing and the background for the underpinning of the discussion before MOLST orders are done. Where the EMOS form is being done, it will automatically show that the patient doesn't have a healthcare agent. It'll drive the provider right to checklist 3. This is a DOH checklist that says the decision maker is a surrogate. If you see this, it's exactly the same language that's used. We have a summary of the discussion that the provider can review with the decision maker to ensure that it was done correctly. This is exactly what you would see on a MOLST form. Same part in section 3 for life-sustaining treatment, with the ability to do partial components of the EMOS form if an individual or the family is not ready to make decisions. And so decision deferred has been put into the application. That will be added to the regular MOLST form once we do the next revision. The health department's not ready to do that because we've been waiting for other changes in public health law. There's a paper version that people can X out if there's not been a decision made. We'll save and continue, and you've really seen the process of discussion and creation of MOLST, at least the input of the information. Once we save and continue, you can see the summary of the discussion and all of the orders. We can also do paper consent, so there can be a conversion from a paper MOLST into e-MOLST, and in other instructions you can see the original consent. From an EMS perspective, that's important because you may look at the form that's dated today, but it may have been an old e-MOLST form or an old MOLST form, a paper MOLST that was where the consent was another day. This is patient consent that aligns with the form. And once we're done with the consent, we'll move down, and again, there's a lot that's based in, so you can do same as above if it's done together. The next is the chart documentation form. Those are of the other legal requirements that the providers need to make. And so from an EMS perspective, you're not seeing this, but that's really the underpinning of that discussion. Anything else that needs to be done, whether it's capacity determination, meeting clinical standards, notification of surrogates, is all the input that's put into this form. And Katie will just move it through. You'll see if it's not appropriate, buttons are disabled. And so it allows the provider to make sure that they're doing it correctly. Once we've gone through this component of the application, we'll have come down to physician signature. Everything up until this component can be done by a trained and qualified nurse, social worker, nurse practitioner in collaboration with the physician. But as you come down, only the physician will have access through the application to sign the EMOS form. So as users of EMOS are enrolled, they will have access to certain parts of the application. It may seem like there's a lot here because there is a lot. So you can see just by the complexity of this form that with Family Healthcare Decisions Act, what providers need to do is far more complex. And then what I've shared with Mike and the folks at Albany Med is as we've been doing paper molds to e-molds conversions, we know that providers need more training in terms of making sure that they comply with the letter of the law. I think if we just move down, Katie, so.
I won't be able to go on.
I know.
Okay.
But you'll see here that the patient does not have a surrogate that's a close friend. All of these were their ex, they're disabled, so the provider doesn't have to worry about it. We also have put in the start and stop times in terms of how much time is spent on the conversation and who the providers are who have done the counseling. And at the end of this, we'll get to the physician's signature. And you'll be able to see at the end of this demonstration how we've created not only the MOLS form, but the MOLS documentation form. If something is not done, there's a bright pink line that aligns here. So Katie will scroll up and you'll see that we have just completed a discussion. We have the documentation of the orders, and we're now ready to sign the form. And again, only physicians have access, and it's an electronic signature that has been approved both by the health department attorneys and the attorneys at New York eHealth Collaborative. There are passwords and images similar to online banking, and it's an electronic signature. The way we can do this with electronic signature is that there's verbal consent with 2 witnesses. So from an EMS perspective, you will always see on an EMOS form verbal consent and 2 witnesses. And so what we've created right here and right now for this new person, Patty Kerpeel, her EMOS form with the EMOS number that was auto-generated on what appears to be exactly a MOLS form that can be printed on pink paper, and as Katie scrolls down, you'll see the dates right here, 12/5/12 and 15/35. What will be different, again, at the top you saw the EMOS number was imprinted. As Katie scrolls down, you'll also see the MOLS chart documentation form. This is what will be in the registry. Obviously, the MOLS form is what you need to see as EMS providers. At this point, there's a lot more to the EMOS demonstration that we could show you, but I would stop to ask if there's some feedback and some dialogue that we can have in terms of EMS. And the big question is getting access to you as providers. And that's one of the pieces that I've been talking to Mike about in terms of at what point do we begin to train EMS, and how do we begin to credential EMS, because what we do in terms of credentialing those who can do the discussion, those that can sign, is that the systems will say, this is the doc, this is the nurse practitioner, this is the social worker who can have access to the application. And these are the users that can help create a form. Physicians can create and sign a form. There's no clinical access, or there's view-only access. From an EMS perspective, you need to be able to view the form. So part of it is getting a critical mass of EMOLS forms before we begin to do EMOLS training is part of what Mike and I have talked about, but also credentialing through some of the systems. So maybe Mike, maybe you can join me up here?
Sure. I mean, basically what, as Pat talks about making sure there's a critical mass, it was Mark Tornstrom out in Rochester chatted about this too. I would not want to start to credential our paramedics in particular with something like this before there was a critical mass to make it worth your while to actually go look people up. And this may be something that as it rolls out place by place may have some real good clinical functionality in Valatia, for example. If Barnwell begins to use this on a really significant population basis, it may be something useful to have you guys credentialed in a long time before, say, guys in Colony or guys in Malta, if it's not being used in any of the local facilities there. Certainly if Albany Med is using this as our in-house, that'll mean that there will be some in the community, but it'll be primarily paper copies rather than having anybody looked up in the community on a case-by-case basis.
Timing is important right now as well, because there's a lot of activity in the Albany Capital District. And so this morning I was with Mike at Albany Med. Tomorrow I'll be with Robert Swidler and folks from St. Peter's Healthcare. And iPro, who's located here, has care transition communities, and they have asked me to do training. I've done training in upstate and downstate on MOLST, and yesterday we did training on communication skills, and in each one of these we've talked about eMOLST, and we're doing a specific webinar then for all of those attendees in those communities. As Mike said, there's going to be variation. We have worked with facilities in the North Country, for instance, and they don't have EPCRs, and they don't have cell phones necessarily, and how we connect with EMS may be different in the Albany Capital District to start with versus the North Country. I've been down to North Shore LIJ, and they have a totally different system down there for EMS that's different than Rochester, than Syracuse. So I expect that there'll be some regional work because of all of the community work that's going on here. So I'm looking to you through Mike to be able to get some feedback on this. Thoughts?
Questions, Chris?
A comment. One of the things in the field, it's hard to get things quickly done. Website and a QR code that links to the website for most people with smartphones. If you could put that right onto the EMOLS form or whatever else, if you can generate that up.
That's a great idea.
Well, we can't edit the form because it's a DOH form, but from the link perspective, that saving it as a favorite, right? We could do, and then making the orders more accessible towards the front, so you didn't.
No, I think actually Chris is giving us something even different. Since we're already looking at this being updated again in August, or whatever their schedule is going to be with changes in the law, when this is printed out, there's no reason whatsoever that it couldn't actually have a QR code on the front in that all that space to the right.
Mm-hmm. I see what you're saying.
It prints out individually for each individual person that pulls up that individual document.
So
and only that code could pull up that document. So the only way you're going to have it is if somebody hands it to you.
Mm-hmm.
Right, so it's counting on paper copies to access the electronic version.
Yeah.
If not,
For confirmation.
If not a highly accessible, just a generic one to get to your login. So if you have that login, a QR that gets you just to your QR codes, at least the website. Not everybody's onto QR codes yet, but everybody's onto a website.
Or you can make jewelry with it. Get somebody earrings and necklaces.
So I think the question in terms of following up on that, how many folks here would have a smartphone that would have access? Because again, that's where we're seeing some regional variation.
Most.
Most?
Let's see, this side of the table, yes?
This side of the table, yes. This side of the table, yes.
I would say 98% of our agency has some Android or iPhone device.
But do you have access? Because right now,
For the most part, we do. I mean, I know some areas don't, but.
would the PSAP have an ability to have access to it?
There's some
Either through the
diff-
district-
There's some different ideas about whether to build this into either some type of BOLO that could be on an address or directly into some other type of dispatching information. One of the things that they're in the process of figuring out how to do would be to do it directly into an EPCR on the backside. So you put the right information in and it pops up pre-existing health information for the person. There's a lot of different possibilities. Again, that's going to be how all this integration ends up working out. Right now, this is a standalone product.
So how many of you use an EPCR at this point? So some in the room and not all. And so one of the things that we've seen as we've talked to EMS across the state is everyone doesn't have access to an EPCR. And that's really where we started building the model in Rochester, assuming that 98% of the folks would have an EPCR, and even the vendors have not really connected to what we want to be able to do. And you're smiling, but that's really where we're struggling with a single solution that is a statewide solution. And that's why we'll continue to work with EMS to try to figure out what it is. Just as much as we started with a Rio model and the rest of the shiny is not ready, we're going to have to do workarounds until we come up with a single solution.
Pat, just for the physicians in the room, how is progress going with the various payers on actually paying for this discussion?
So in terms of paying for discussion, Excellus Blue Cross Blue Shield came up with an improved reimbursement model to incentivize physicians to spend the time to do the thoughtful discussions, and we built the model with providers. We have gotten MVP to accept the model, and I've been given an entree to talk to the Health Plan Association that has other providers. I think their next meeting is in February, so hopefully they will get me on the agenda and we'll get other payers. Unfortunately, the major payer is CMS. And when we started with our model, the Affordable Care Act was just getting started, and there was so much that was going on. There were 2 pages in the Affordable Care Act that were X'd out that it was thought that it would include it. So there's opportunities, I think, and I think, frankly, the more that we get payers in New York State involved and we're able to show that this does make a difference in motivating docs, we might be able to bring that to the major payer. Because, frankly, it's older folks that, the majority of folks who need a MOLS form are older folks. It's not exclusive because we know babies are born dying, and in fact, the first MOLS form that was created at Albany Med was on an infant. And it didn't come from a provider, it came from a mother who knew about MOLS and she was taking her baby home to die. And a surgeon called and said, I want to be able to do MOLS for this mom, and it was done on a Friday afternoon. But again, the majority are older folks. Other thoughts that folks might have? I like the idea of the QR code. It was raised elsewhere in one area, but we need to be able to wait, because we do the MOLST update once a year, and we're going to be aligning e-MOLST updates at least once a year.
With the QR code, you could even print out a bracelet with it on it. So rather than carry around the pink form everywhere they go, it's so we'd see sort of like a DNR bracelet that other states have done that would link to the full form.
It's an interesting idea with the bracelet. In fact, in 1987, when the DNR legislation went into effect, the state was supposed to come up with the DNR bracelet, and I talked to the health department about what's the prototype, what do you have, and it never was really created. There was one case that a family connected with me because it was a person who left the hospital, wasn't in this area, didn't carry their MOLS form around because they were taking a walk in the neighborhood and had a cardiac arrest and didn't have the MOLS with them. So I like the idea of being able to have immediate access. And then it's really the training to make sure that people wear the bracelet. And I think that because it's a very smaller population, and if people are trained, and more importantly, families are trained, that would happen.
Yeah, I love the QR code thing too. I think like that we have to figure out how to balance security, obviously, against access. I lean on the side of accessibility personally because I think these orders should be that available, but there are obviously people who think you shouldn't be able to just scan someone's wrist, you know.
But link it to your credentialing for the EMS that are gonna be looking at it.
Yeah.
So, yeah, it'll bring it up and say, like, to go any further.
To log in.
You need to log in, but if you used to do that, then to
Then it would redirect.
type in the website, search the person's name,
Yeah.
then it would be to just scan it for your password.
Yeah. We've also been talking about pulling the orders up so that even when you got the person's name, you'd have the PDF there for you if you want it, but that you would see the orders right away, like the summary basically, which I think would be helpful.
So one other question we had, Mike and I have talked about credentialing, particularly of the paramedics, the EMTs, and my question is, how would we get to first responders, fire and police? And what kind of training has been done on most in this area for first responders? Because page 1 is the equivalent to the non-hospital DNR. And, you know, we haven't thought through that in terms of EMOS, but I was curious as to what's happening with fire and police in terms of MOLS training.
Nothing in our area.
Not in our area.
I would say they have access to the same, the same notifications from the Department of Health as we do. If they're a certified first response agency, you know, they see the same policy statements that we do. And when this came out, you know, it was pushed by the Bureau. But beyond that, I think they probably know. I think most of the ones we work with probably know that it exists, but they probably don't have working knowledge of it.
Is there any way to improve that? Is there a-
Probably if we do it. Yeah.
Because that's one of the concerns, and I know as a geriatrician, oftentimes if my patient had an issue at home, sometimes the fire department or the police responded first, particularly if they fell, and there might be more than just the fall. What's the underlying cause for the fall?
Truthfully, I've seen very few outside of the nursing home, MOLS forms.
Okay.
I've seen very few, and it may just be a community thing. I don't know what the rest of the people are experiencing, but.
Well, that's a good point, and I think, again, with iPro working with these communities, and they're all really in this sort of centralized county area that you serve, we may see more MOLS forms out in the community, we may see deeper penetration, and that may be a time to ensure that the fire and police are really understanding what MOLS is.
If I can expand on something that Scott had just said, I think part of that comes down to that I think primary physicians are unaware, even at first for the longest time, of just what a non-hospital DNR is and getting the patient to the right DNR, let alone understanding that there's a better option in the form of a MOLS. I think that most primary physicians that we deal with are unaware of a MOLS in the first place, or unwilling, one or the other.
I've got a lot of work to do before I need a MOLS. Any other thoughts, last minute thoughts? I really appreciate the time. I want to thank Mike for giving us the opportunity today. And if you have thoughts afterwards, and if you see that the penetration as it's moving forward in this community, and you have further ideas, like the QR code, which I think is an excellent idea, you can always get them back to Mike and he'll bring it back to the state MOLS implementation team. Thanks a lot.
Thank you. Thank you.
Thank you.
Thank you for the opportunity.
Thank you. Absolutely. How do we turn this on?
We got it, or it just goes off? It's going off. Perfect.
All right, guys, well, thank you. It was a nice start to the meeting here. Let's just jump right in with some business. We can. Chris, Tim, do we have a quorum? Please tell me which one.
Tim,
Yeah. Thank you. Okay. Excellent. What did you say?
We have no quorum to discuss a quorum issue.
Exactly, exactly. So I'd like to do is first, can I have a motion for approval of the minutes from November? Motion? Excellent, seconded. Excellent. All in favor? Thank you. Let's start with reports of committees, please. We'll come back to correspondence in a minute. Academic committee.
Academic committee, not a whole lot. Basically, Rema's going to be doing national standards update training. We'll get information on soon. There are a lot of EMT courses that are available. The list is minutes. And there's no meeting in January.
Excellent, thank you. Which will be one piece of new business, right? The REMSCO did not have a quorum and therefore did not have a meeting to discuss business. CMAC, SEMSCO, and HOC, no reports. There is a CMAC and SEMSCO meeting at the end of January. Back to correspondence quickly. Correspondence for me. Dr. Vogel was nice enough to be here. No, you were excused.
I switched my shift.
Thank you very much. I appreciate that. DiMartino, Bosco, and Mao all begged off. Did everybody see the email from Dr. Cushman about just some interesting new topics? I thought they were very interesting for us to give to the protocol committee for the future. The first, the split of the advanced directive into termination of death and termination of resuscitation protocols, make it a little bit easier to understand. A split again in the excited delirium and behavioral emergencies protocol. The addition of ketamine both into the excited delirium protocol as well as into the RSI protocol. I like this in particular because it's making Jeff's eyebrows go up. And possibly one of the most interesting ones that I think will end up leading to the most interesting academic discussions, which is to switch to norepi from dopamine as pressor of choice, which will actually be much easier from an administrative perspective, or administration perspective rather than administrative. So interesting ideas, but hopefully everybody had a chance to look at this. And this has been passed on to the Collaborative Protocols Committee, and they will continue to discuss it as we think about it locally. Any thoughts at this point?
Well, if we're going to norepi, because that's becoming the standard drip for everything, so why are we doing dopamine in the field and just change it over when they get to us?
Gotcha. Any other thoughts, Bruce?
Oh, I love the idea of ketamine. I think of many other uses than what you just put out, but it's nice to start slow and then work your way up, get people comfortable with it.
Mm-hmm. Well, the simple answer for ketamine from my perspective was that I didn't want us to get anywhere near using ketamine in our pre-hospital arena until we had all of the constraints taken off it. Initially, when ketamine was brought up for use and has been approved for use by the Bureau of Narcotics Enforcement and the Bureau of EMS, it has very specific restrictions as to what it can be used for. Which is very different than all of our other medications where the decisions on use are not made by regulators but are made by the physicians who are writing the protocols. So hopefully those restrictions will be removed both by Monroe Livingston asking for ketamine in this setting and New York City's rescue protocols, which are also coming up in January. So there'll be some interesting discussions at the CMAC. There was a matter that will not take place today, and just an interesting, by the way, is that Skidmore College is forming an EMS group, which Al Jagoda is going to be medical director for. So there will be some EMS available on the Skidmore campus, and one more collegiate EMS agency to come help out at special events, which will be really nice to see. I had a chance to go up and lecture for the group. They're very enthusiastic, and actually I met a bunch of these Skidmore folks, very enthusiastic. Union is extremely
active right now, which is interesting to watch. Some agency upgrades, EpiPens at Greenfield Fire, the BLSFR application, and public access defibrillation, nothing exciting. New business. The first piece of new business that I wanted to talk about is what we do if we don't have a quorum. Rich can speak to this as well, but a number of us were absolutely horrified that people came together from all over the state only to be sent home again by the state with no business being done because there was no quorum. This was mainly because of an interpretation of statute on the part of the legal advisors to the Bureau, but I think from a local perspective, the time that our local physicians and members of our medical advisory committee is no less valuable. And I think if we come together, we at the very least need to find a way to take care of business and then from a policy perspective, be able to vote using people's phoned-in votes if necessary, or to conduct business via computer approval if we discuss it in a group here. I'd also rather have our discussions when we don't have a quorum take place on camera so they can be shared and people can view those, and then they can be viewed by people who will later ask to vote for approval on matters that we discuss. I'd love to hear thoughts from the floor, but I just want to make sure that we're making the most effective use of your voluntary time because frankly that's one of the most valuable resources, and this is such an incredibly vibrant group of folks. I want to make sure that we're not wasting anybody's time. So any thoughts from the floor?
Just one piece that I think may be missing that is, why is it we're not getting a quorum? Needs to be asked too. Is this a bad day? I mean, this has been the day since time immemorial, since I was a resident when we met, but maybe this isn't the right day for this group. I don't know. Maybe we have to move times. I guess I would query the people and say, why is it you're not able to show up? And if it's the same answer, well, that's the same time I meet with my CEO and we need to do something. Or if it's lack of interest, just dig down, why is it we're not getting a quorum?
It's rare when we actually don't get a quorum for this group. In fact, when was the last time? Anybody know? I mean, last month we barely got there, right?
That people showed up like we did.
We got there, but frankly, I think what's most important is we can certainly put it out. The last time we looked to find the best date, we ended up right back at this date again. Maybe it's time to look for it again. There aren't a lot of people with standing commitments that I know of.
And the time is a little odd because it covers all 3 shifts that occur during the day at my hospital. You can't do the 7 to 4, the 3 to midnight, or the 11 to 10.
So we're giving you a day off.
Yeah.
No?
Sure. We'll go with that.
I mean, one thing might maybe change it to 4 o'clock. I mean, maybe that makes it a little bit easier for some folks. I mean, meetings usually don't last more than an hour, so 4 o'clock.
And I think actually what makes the most sense, and I think, I say tongue-in-cheek, do you get a day off? You're absolutely right. We don't want to we want to make sure that we can get as much availability from people as possible. Deb right now, as much as she wants to make meetings, has not been able to make meetings because of childcare, and has talked about it being earlier, which is one
10 o'clock in the morning would be great. You could still catch the afternoon shift. The kids are in school.
We'll do that, make it 8 o'clock in the morning.
They're not on the bus yet. They got on the bus at 8:45.
9:45. Well, no, I think actually we have to not only allow Sarah to get the kids on the bus, but she
Have time
also
to
then
bake.
has to have enough time to bake in order to bring whatever she has baked here. So, there's a whole lot of idiosyncrasies we really need to work out here.
But it would open up a whole new breakfast avenue if we did the 10 a.m. thing.
It's true. Move it to 11, we can hit brunch.
Brunch.
Yeah.
It's true.
As long as it involves Reese's and marshmallows.
Then we have had leftovers for the QI committee left.
Okay.
So, Tim, if I can impose on staff to find some type of scheduling software, and there is free scheduling software out there that can help us delineate when the best times and days would be. And let's see whether or not we can make a change for, at this point, people have probably already planned their lives through February. Let's look to see whether or not we can start. Does March seem reasonable if we come up with a better date? And we will
Assumption
use.
is you're gonna need to move academic as well.
Yeah,
So
we
you
just
need to talk to
say the
these
same
people
thing.
too. We wouldn't be doing, I mean, most everybody wants to be there, so you're not only scheduling positions, which we seem to have a problem with, but we need to talk about all the people from EMS.
Well, we've got academic, we've got QI, and we've got the MAC. Most of the people who are on academic will hopefully become interested in becoming a part of the QI committee. There is overlap on the other end of that too. I'm not sure we're really going to be able to keep it as Remo Day if we, start looking for all of these things.
8, 9, and 10.
8, 9, and 10.
Almost as good as 5 and 2.
We'll never get Dwayne out for more than 8 to 8:15 or 8:30, and he's going to be dozing.
Well, I can start early. I just don't want to start in the middle of the day. I'm getting no sleep.
Let's start with the docs, and then once we've got some doc consensus, then let's put it out to the academic folks, and then we'll make a decision as to whether or not we go back and reschedule QI after finally finding a time there.
On the flip side of that is we still should probably go back to the original part of what you're doing over before. Because you're still, no matter what time you move to, you're still gonna run to a time where move 6 people showed up.
Absolutely.
I think you should allow electronic input.
What if you did a survey monkey? Send it out to the group, explaining what your position is, what your involvement is, what your availability for time is, and then see what, based upon, have someone, doesn't survey monkey collate that? We can actually see what everybody's input is.
We also do a survey monkey for this is the issues we voted on. You've got 2 weeks to put in your vote. So use it for now.
I would rather not tie us to a specific software vendor.
Or email.
Or email, which I think is probably going to end up being our best bet. But just to throw it out there, what are we going to do when there's no quorum?
And also in the past, we've done conference calls. We've called people up and said, here's our discussion, sit and listen to it, tell us your feelings. And that's worked in the past. We've also done the remote video, which we did up at Wilton for a year or so. And that worked well, for that time frame too. So that might still be another option to get people to not have to travel.
I guess we could hook this to do it live, couldn't we? Maybe not.
We try something.
We could try something. So we'll leave remote video as a maybe.
No reason why you can't be doing Skype. I mean, you can pick up your iPad and have real time with Skype. Why not be able to do this?
Matter of FaceTime?
I mean, I would speak towards the use of technology as much as possible. If you take a look at why these rules are in place, it comes from Robert's rules, which are very, very old. And the fact that just to make sure that meetings and decisions were made of a significant group that represents the whole. So I think that using any of these technologies, regardless of what it is, would make absolute sense, and it's contemporary as opposed to, practice from the 1800s.
Thoughts?
We're routinely, at LifeNet, we're routinely using Adobe Connect for our monthly CQI. We have 10 bases that are attached, and we record it, and all 10 screens are recorded so that we actually goes into our minutes.
And there's also a version of Adobe Connect that works with Google, and Google, I want to say it's Google.
Chrome, you're talking about the browser? Or are you talking
No, it's like a Google nonprofit or something.
I think one of the things, if we can actually have you guys bring in computers next time, we can test it out for the February meeting and have it, try to get it in place by March. We'll have a couple different things and we'll have to try it out and see what works best with 6 people in the room that are using the computers. So, and then we can work that to the outside world.
Gotcha. Rich?
at some point, I think this was kicked around for discussion a couple of years ago, but I don't think it was ever finalized, maybe I'm mistaken. Remac should probably adopt at least some simple bylaws that would cover this and reduce the running. You could certainly have the language allow you enough latitude to work within the, whatever current technology is. But you should probably put something in writing at some point. Remsco has bylaws, Remac does not.
That's a good point. That actually came up in discussion, I think, when you were executive director. Haven't heard hide nor hair of that since, actually. I can't even remember who we put on that bylaws committee.
I don't recall either.
Brian? That's a good idea. At the very least, I think we've got a really good idea, which is that when we have no quorum, it would be very reasonable to allow, no present quorum, it would be reasonable to allow quorum to exist via technology. And that would be reasonable, because I think that the idea behind the governor's directive that led to our videotaping was that we would have open meetings, and people would be able to then look at that meeting, and they would be able to hear any discourse that was going on that we were to bring in via technology. And I think that was the intention. I don't think we're violating the rules, still availing ourselves of the ability to conduct business. Does that sound reasonable to everybody? Okay.
Soon it'll be you sitting here by yourself and everybody else will be in the kitchen with their computers on.
Just as long as they have pants on. So.
Or the camera's in high.
That's troubling, Dr. Ashcroft. I think we should look into the ability to do something like the Adobe Connect, because I think that's a great idea. But the policy that probably makes sense to come from this would be, if we have no quorum present in the room, that we allow a quorum to exist via technology.
Why wouldn't you allow someone who can't make it, Sarah's home with a kid, to chime in even if you had a quorum?
Oh, yeah, sure could.
Oh, no, I wouldn't in any way use this as opposing the ability of people to chime in anyway. But I think when this really becomes important is that we still exist as a group, and we still exist as a group that can function and conduct business without a quorum present in the room, as long as we can get a quorum, because our quorum is actually listed in the...
It's in your quorum is defined ironically in the Remsco's bylaws where it really doesn't belong, but there was no other place to identify it, I guess.
Okay.
So the Remsco's bylaws really aren't binding on the Remac, I don't think. That's the only place you'll find the mention of 7 ducks, 7 positions.
Is in the Remsco bylaws.
The Remsco bylaws, correct.
Well, until they're changed there, they exist there, so we need to make sure that we live by those. Do I have a second for my motion for allowing participation via technology? Yes. All in favor? Any opposed? Excellent. Thank you very much. I appreciate you all taking time with that. Before I forget about it, because nobody wants me to, I would like to make a motion from the chair to cancel January's meeting. All in favor? Sorry, second? Thanks. Now all in favor? Thank you very much. With no further ado, I'd like to turn the floor over to Dr. Tilney for a piece of new business, which is going to be TXA. There's a document that we just printed out over here that we can pass around as well. Make sure everybody gets a copy.
We're requesting as a group, we're passing around a document, which is one of our patient care guidelines, to introduce a medication on the aircraft called tranexamic acid. It is an anti-fibrinolytic that has gained some significant notoriety in the last, year or so. There have been 2 large-scale trials, one of which was called the CRASH-2 trial, which was done internationally, 140 countries, 22,000 patients. This is an old drug that's been around since the 60s, and its use has primarily been in first OB-GYN and then now thoracic surgery, cardiothoracic surgery. And essentially what it does is it's an antifibrinolytic, so it allows bleeding to occur and clotting to occur in the right places. So where bleeding needs to occur, it allows appropriate bleeding, so maintaining patent arteries and veins. But where you need to have appropriate clotting, it facilitates that as well. And the second trial that was used is called the MATTERS trial. This was used in the military arena, and they've had really, really great outcomes. What's really interesting about this is there's nobody really doing it pre-hospital. There's been some discussion out of the special ops down in the city, but we plan to introduce it onto our aircraft and hopefully follow closely by the Colony aircraft in this region. Albany, I also wrote the protocol for Albany Med. It's really easy. It's a gram of this medication over the course of 10 minutes, and then followed by another gram infusion over 8 hours. A dedicated IV line, and the only caveat is that needs to be given within 3 hours of the injury. So this makes it a perfect pre-hospital drug, actually. There's very little side effects. The side effects are only seen after the 3-hour window, and even then they are limited. It's just there's no sort of bonus of the effects. And this would be specifically, if you see it, and I pulled it directly from the CRASH 2 and the MATTERS trials, but it's those folks who I specifically are in hemorrhagic shock. So those folks that the pre-hospital providers or the providers in the emergency department identify as those people who are going to get transfused with any type of blood product, whether it be packed red blood cells, FFP, et cetera, et cetera. And so once identified, they can say, so on the 2 aircraft, 2 flight services in town, once they're identified, they'll get the first bolus, and if they do the first bolus, then they'll begin the infusion that'll continue during the next 8 hours. Albany Med is the only hospital in town right now that is planning to institute this policy. We have buy-in from the trauma services at the Med, but I anticipate, just like we did a few years back, I anticipate that this will become sort of the standard of care, and other hospitals are quickly to join in. The interesting thing about this medication is A, it's been around for 40 years, and B, it's $16. It's super cheap. Nobody cares about, the price of it it's excellent. So with your approval, we'd like to start initiating this. The goal will be to do this beginning the first of the year, or when we gain approval from the pharmacist at the Med, which is probably next week. Questions?
How long is Albany Med conclusion do you expect?
So we have not put it in effect. I'm getting approval here in the next week.
Okay, so they haven't used it all, but you want to put it in the field at the same time as the hospital?
Correct. I had to get buy-in from the hospital first before I could ship, and I have buy-in for both. So as soon as they give me the green light, I'll put on the aircrafts.
Europe uses it like water.
Absolutely.
Yeah, Bruce, nothing's changed. It's still easier to change things for most of the pre-hospital world before you can change them home.
It's also be a good time if we're going to be doing that, knowing that once Albany Med starts doing the descending hospitals, we'll probably be starting at 2, adding this to the facility lists. So if we're starting the infusion, that we can continue that.
That's a great idea. What was that? Mike, anything to add?
I think Pete did a great job. I mean, this is an incredibly impressive medication that's relatively safe. When you take a look at what it does, it's cheap. It's sort of almost, it's pretty straightforward in my mind. Great experience with it in the clinical trials. Probably the only good thing that's coming out of some of the wars right now is some good medicine that's being practiced there. And we've seen that this is very helpful here. Let's just hope that we can do it, and let's just hope that we don't have supply problems at some point with it. But,
The other thing that specifically from the hospital end, we will be able to track the caveat that I had from the buy-in, the caveat that I have from the trauma service at the Med, is that they're going to follow all these patients who get this medication specifically, and they'll be and so it's going to be in a separate database so we can track outcomes. And then based upon their sort of CQI system, we'll revisit this 6 months to a year to see what the, what outcomes are. And I don't think we have really, in the CRASH 2 trial there, US side, there was not a huge amount of participation. So it'll be really interesting to see how this kind of pans out in a year or 2 or 3. And there's, a variety of studies that are coming along that is pushing this. We'll be tracking it in our own local region as well.
Sorry for being pointing at it, but it's my nature.
No.
Are you also doing permissive hypertension at the same time? Because it's going to be the same patients, and that's going to screw up your data.
That is going to screw up the data, but yes, they're doing that already. I mean, there's a lot of push on that sort of as a standard of care, as you know. And I don't know how you, that's a good question. I don't know how you track that. Right, I don't know, right.
So is AMC doing permissive hypotension now, and if so, for how long?
We are doing it. I don't know what and I don't know whether they're tracking it, but as a clinical practice, we are doing it pretty routine. And in terms of how long, I don't know that answer.
Are you doing any randomization as far as not everyone gets it? Do you do some sort of a case control, or is it basically everybody who's coming in this criteria?
I think it's by case basis.
Maybe we're saving to have some comparisons.
Absolutely, no, that's a very valid point.
And obviously, we've been talking about this for a while now, both in the hospital as well as for pre-hospital use. From my perspective, I thought about the possibility of bringing it out, using it across the board in ground services. I think there are a number of different factors that make using this just by air right now the safest and most reasonable way to institute this. First, we're in an in-between year for protocol cycles, and it would be very difficult to institute something new across all of the region for all of our providers. Even though the cost of the drug is cheap, the amount of education that would have to go out there in order to get people to use it would be difficult. I think the other thing that's really important is, well, let's trial it on the aircraft. Let's make sure that it gets used safely, appropriately, and well on the aircraft first. This is how we did on Dancitron when we first broke on Dancitron in. This is where we started with fentanyl as well. And I think taking those steps along the way really is the most reasonable way for us to move forward. If at the end of the day, we look at this and we say, something worked out really well, 2014 will be a time to update our protocols anyway, add it into the protocols and the educational materials for that for 2014, and then continue to move on from there. So that was my thought process so far with this.
The other interesting thing is we are only using it, the caveat right now is there is only a handful of hospitals or centers that are using this medication. So right now, it's the caveat for the flight teams is going to all the med, because that's where it's going right now. I can't speak to the other trauma centers in the area, whether they're using it, and I think there's a variety of centers that may or may not be using it. It's not standard of care yet. It will be probably in the next few years, but we're really early into this, just like we were, again, 5 years ago with TH. I think that's what we're seeing. Thanks.
Great point. Any other thoughts? I have a motion.
I make a motion to support the movement towards the DPA Act.
Okay, thank you. Multiple seconds. Any discussion before vote? All in favor? Any opposed? Excellent. Thank you all. Dr. Tilney, thank you. I have a completely blank space for old business. Anybody know of any old business? I don't. Any items from the floor?
Old business last month, I've got a note here that Dr. Duthaler had raised concerns about pain management protocols. It says agencies are critiquing providers who give 4 milligrams of morphine. There was a discussion, and the note said that the issue was to be discussed at the next meeting after a protocol is served follow-up.
That's a great thing for us to follow up on.
For next month, February, for next meeting.
Copy paste.
And I don't, yeah, copy and paste. I don't remember any discussion. Did we do a discussion on that?
We talked a little bit about it. It's basically a couple agencies out west who are nitpicking the narcotic dosing. If the protocol says give 2.5 or 5, and somebody gives 4 or 1 milligram, then they were getting written up in QA because of that.
Yeah, I don't remember whether or not we ever put that out over the protocol listserv and there was any further discussion.
There's nothing I got a note about.
I can be honest, given the amount of discussion that's been on the protocol listserv over things like norepi that really are important discussions, I can't think there's going to be a whole lot of discussion over a 0.5 milligram of morphine.
Probably,
So-
I would imagine the 4 milligrams is to save the waste.
Right, a lot of it is
Because it
to do
comes in
with
twos and
what they have
fours.
available now.
Yeah.
Yeah, it comes in 2s, 4s, and 10s.
Regular basis,
Exactly.
And
Is appropriate.
my response to them was, don't be so nitpicky.
Exactly. Up to.
Yeah, don't cut and paste. Item closed.
Don't be so
nitpicky. Don't be so nitpicky.
No action
Minimize
for that.
waste at
No
all
action taken.
times, period. All right. Anything from the state? Nothing. All right, well, if there's nothing else, we have a motion for adjournment, please. See multiple seconds as well. All in favor? Thank you very much, everybody.
Merry Christmas.